So thank you so much. I'm really excited to be up here and talking to you, and I was thrilled to really be invited to this session because everybody in this room represents our future. You're all the future leaders that are going to come up within the organization, within your institutions. How many residents do we have in here? Fellows? Lone medical students? Wonderful. So I was tasked today for letting you know how you're going to get paid when you finally get out there. Full disclosure, I've only ever been in an employed model. And I'm happy that my slides are going to take a little bit of a bend because I actually learned a lot from your talk, so thank you. These are my disclosures. Essentially, I don't think any of my industry disclosures have a role here, but I do want to say that I don't have any idea about whether anything I tell you in this talk is going to be relevant in the next 3 months. So you can imagine where I'm going with this. And that's healthcare, the 30,000-foot view. And a lot of this is I want to explain to you what's going on out there for you to understand where you fit in the picture and how this rolls down to your paycheck at the end of the day. So we have a problem in this country, and I don't think anybody in this room isn't aware of that. And when you look at the 30,000-foot view here, our gross domestic product and how much we spend on healthcare is disproportionate to the rest of the world. And if you look at the data that comes out of the Commonwealth Fund, it's not just that we're disproportionate in spending, but we're also disproportionate in outcomes, right? Because you could make an argument that if we were spending a lot but getting a lot of value, maybe that's okay, but we're not, right? We're not #1 in the world for mortality. We're not #1 in the world for cancer treatment, so something's gotta give. And really, Medicaid and Medicare, where a lot of the money that's supporting you right now comes from, constitutes almost over 20% of our federal budget. So how do we handle these costs? What do we do about this non-sustainability? So back in 2008, 2009, 2010, when people were really starting to think about this and there was a tipping point, we really kind of had to figure out what to do, and there was sort of 3 strategies. One, we could have a one-payer system. I think we can all figure out why that didn't work. Obama at that time was already being a socialist and a communist, so really throwing out there, let's have a one-payer system like they do in other countries, wasn't gonna work out. The second thing they thought is, well, maybe we can increase the consumer price consciousness, right, to combat price immunization. If you don't know how much something costs, you might just be ready to use it kind of willy-nilly, right? If you think, oh, it's no big deal, everything is free, then you won't value it and you won't be thoughtful about your utilization. And some of this has made its way into the ACA, and that's where you see and hear things about high deductible health plans, transparency on charges and on quality to make the consumer aware, your patient aware, and you aware of what things cost in the hope that that will drive down prices and increase responsibility. And then the third aspect, and this is really what drove the Affordable Care Act, or the Patient Protection and Affordable Care Act, is that our costs are high because the providers, you, all of us up here, not your consumers, the patients, need a financial incentive, are the problem, and that really there needs to be a financial incentive to be cost and quality conscious. So this is the old adage of the carrot and the stick, right? The carrot leads you somewhere good and the stick kind of hits you down. Here they thought we really needed a stick. And so all of these things came together, and in 2010, we signed the Patient Protection and Affordable Care Act, and here's a really great picture of President Obama. Now, who's been following in the news in the past couple months? I don't know where this is going, right? I don't know if you guys saw this morning, but I guess President Trump's latest tweet, because that's how he communicates with us now, is that he put an ultimatum to the Republicans that if they don't vote for this bill on Friday when it was supposed to be voted for, then we're just gonna have to go to Obamacare. So I don't want to be political, but fingers crossed. But at the end of the day, I don't really know kind of where we're going and what we have. But the point of this bill was, for the first time, it's linking your payments to outcomes. So instead of you being fee for service, volume driven, how many RVUs can I produce, and that's how I'm going to get paid. Now you got to show what you're doing. What are your outcomes? How are you performing? And they chose 3 target measures, one on readmissions. I'm sure everybody's been heard of. How many of you had a panel or grand rounds on readmissions at your hospital, teaching you how to not readmit patients or put them on observation or how to prepare them before they go home? So this has touched all of your lives already. Value-based purchasing, which I'm not going to go too much into today, and then the hospital-acquired conditions, which are essentially 10 measures of outcomes, include things like development of abscesses or other hospital-acquired things that happen. But really, for the first time, what this bill does is it puts an increasing portion of the hospital's inpatients payment at risk, particularly for hospital-acquired readmission. So if you think, I'm getting a salary and I'm a hospital employee, or however that money is derived, your money is at risk because of these outcomes and because of these bills. And for those who don't think that this is going to touch us, it's coming, right? In 2013, when they kicked off the program, yeah, they focused on the medical conditions, pneumonia, congestive heart failure, acute myocardial infarction, low-hanging fruit. But you know what in 2015 they started? They started with hip replacement and knee replacement. And in 2017, they're going to cabbage. So it's really only a matter of time, again, if this maintains relevant, that this is going to touch all of our lives. And so, because of this, we have to do reported measures of quality and outcome. Have you guys heard of PQRS? CMS loves throwing like lots of words at us so that we don't understand it. Have you guys heard of this? Good, a couple people have heard. This is the physician quality reporting system. These are metrics as an individual or as a group that you report outcomes to Medicare. And based on these metrics, you can have either a negative or positive adjustment. And you're always going to get negatively adjusted if you're a non-reporter. And essentially, you end up reporting 9 measures, and there's 284 endorsed measures in CMS. And these are the surgical measures that they have on the individual level. Anastomotic leak, unplanned reoperation, unplanned hospital readmission, and surgical site infection. Does this apply to everybody? Does this apply to everybody in the room? Is this fair? Is this how you end up wanting to be measured? So why should we care about this? Well, not only are these measures reported to Medicaid and Medicare to judge you on, but they're publicly reported. You guys have heard of ProPublica and all the things coming out that tells all your patients what a great doctor you are based on the 20 gallbladders you did. These are all publicly reported. And they passed a bill in 2015 with the new framework, which is allegedly supposed to reward better and not more care, and combine all of these quality reporting programs in one system. Now, this slide is a little bit busy, but the whole point of this slide is to introduce you to something called MIPS, which is the Merit-Based Incentive Payment System, which is DocFix, and this is supposed to help you. And essentially what this is going to be is you're going to get a score at the end of the year, and it's going to be out of 100, and it's going to take into account different things. It's going to take in your PQRS measure, which are those quality reporting measures, your value-based payment modifiers, your utilization of electronic health records, and it's going to give, and then your continuous quality improvement development within your practice, and it's going to give you a score. And this is meant to be a zero-sum game, so not everybody is going to be a winner. And based on that score, you're either going to be a high performer or a low performer. And if you're a high performer, you're going to get rewarded, and if you're a low performer, you're going to get penalized. And again, not everybody is going to be a high performer, because the thought is to make this budget neutral. The lower performers will end up paying for the higher performers. Scared? I'm scaring everybody? And this is really the timeline for this, right? So we're already kind of in action, and this is all really meant to be rolled out, I think, by 2020 is when it's supposed to all kind of go up. But you really have up to 9% of money at risk. And if you think about most hospital budgets running on a 1% to 2% margin, if you put 9% of Medicare payments at risk, that's a big, big deal. And again, will impact you, and we'll talk about that in a second. The other thing they're trying to do is to incentivize people to band together into what's called alternative payment models, and that's kind of beyond the scope of this, but I'm happy to talk to anybody about this. So to reduce the risk, but it's also a risk undertaking. So this transition is happening. The past is fee-for-service. The present is value-based purchasing, shared savings, bundles, partial capitation, and in my future and what I think the future looks like, we're going to move to full capitation. And essentially, this is a busy slide also, but the whole thing is you're going to be the ones at risk. You're going to have a risk-bearing organization within your hospital, within your practice, whatever it is. You're going to receive a lump sum of money, and you're going to have to figure out where that goes. And you can imagine all of the conflicts and issues that that's going to bring up, and how that has to be done very thoughtfully. So how does this translate into value-oriented provider compensation in an age of payment reform? What does this end up meaning to you? So, as we just heard, compensation models are extraordinarily complex, and no two compensation programs are the same. Even within the same institution, people can have different compensation models. And the methods for defining your base compensation are based on a bunch of different things. You can have a flat salary if you're hospital employed. It can be an RVU model. You can have modified production models, which take into account RVUs, clinical academic productivity, education, service. They can be really, really quite complex. And really, the percentage of compensation that's not linked to salary or productivity is very, very variable. So my compensation model, which it may reward me for whatever academic effort I do, may be very different from you who's only RVU based. And that's why it's really important to get down to the granularity of it. But there's essentially 6 domains of what I call value-oriented measures that are put in when you look at MD compensation. The first is clinical quality and patient safety. How well are you doing? What kind of quality are you performing to your patients? How is that going to be measured? Patient satisfaction. We may not like this, but we all get a score. We all get evaluated. And that comes in when you get your scorecard at the end of the day. Do your patients like you? How satisfied is your practice? Access to care. How quickly can a patient see you? Citizenship. How do you act in your surrounding? Are you a good citizen? Do you participate in committees? Do you go out of your way to teach, to mentor, to do your research? Are you part of your community? Efficiency and productivity, which typically ties into the either education or academic piece. And then the health information technology use. Are you your EMR champion? Are you furthering that cause? How's that going? And that's a very valuable piece. And if you can get involved in that and figure out how to leverage that to make your institution better, that's only going to really increase and up your value. And then there are always some metrics that are derived from measures that are homegrown, things that are important within your community, within your institution, in your setting. So really the takeaway is I don't want anybody to be scared, but the country is changing. I don't know what the impact on the individual or organization is going to be. I don't know what's going to come in the next couple months. I don't know if it's going to be the same, if it's going to be different, or if in 6 months I'll be up here next year telling you something completely different. I hope not, but we'll see. Compensation plans vary. They all do. They're really variable, and you have to take the time to understand your plan. And if that's the one message or theme that keeps going today is you're responsible for yourself, and you can get whatever lawyers, whatever you want to look at it, but at the end of the day, it has to match your values, your mission, and your priorities, because when they align, it's nothing but success. And always understand how you're measured. So thank you very much, and thank you for having me.